Gosh, I was about to say what today's topic is, and I'm not even sure what the name of the topic is today, which is terrible. I drove down to Newcastle yesterday and on Monday, and then drove back yesterday, so I'm a little bit tired. I know that we have a panel of presenters today, led by Dr. Ian Charlton, who's going to use his whiteboard, which is always very entertaining, which will be great. I will put the Slido evaluation link up in the chat as we're going along this morning. So if you could fill in the evaluation, that would be much appreciated. I will send it out by email as well. All right, Georgia, I might hand over to you.
Yeah, and I'll do an acknowledgement of country as well. I don't know if we did that yet. I'd like to acknowledge the traditional owners of the land and pay our respects to those past, present and emerging. We're here on the beautiful, what we call land. So ducking jumping. Sorry, in Newcastle last time. Yeah, ducking jumping. There might be, I think Chris might be on the Wobble land. But yes, welcome everyone to our first vertical integration session of the year. So we've got a great lineup, a great expert panel here. So consisting of Ian Charlton, who's a local GP at Kincover. We've got Dr. Kristen Gibbs, who's a GP at Your Family Doctors at Erina. And then we've got Dr. Kelly Hawkes, who's a registrar at Your Family Doctors at Erina. And then we've got Joseph Fletcher, who's a medical student who's in Tamworth at the moment. So, and we've got an exciting lineup. So our topic today is to treat or not to treat. That is the question. So in regards to antibiotic treatment. So far away, Ian.
Oh, very good. Well, thanks everybody. This is a topic dear to my heart that I've been wrestling with for 40 years. I realised almost at the day was when I first did my first general practice locum in my dad's surgery up there at Charlestown in Newcastle. Ever since I've wrestled with the idea of should I use antibiotics or not. I've been exposed to lots of information over the years about antibiotics, various studies, this and that, but I still find it about the hardest question to answer in general practice. And so I'm delighted today to have lots of GPs available to lend their experiences to whether to treat or not to treat, because I'm pretty sure it almost does come down to the individual doctor and the individual patient as to whether you treat or not to treat. The other thing I'm very interested in is how you communicate your ideas to the patient. So it's one thing to have 5 or 6 years at university, to have all these studies at your fingertips, but then it's a matter of being able to communicate that information to the patient in ways that they'll understand and then follow the instructions. And there's quite a number of vital steps that can go astray. And if we don't communicate properly, well, then the patient's, the whole process is lost. If the patient doesn't put those communications into action, the whole process is lost. And there's a lot of inefficiencies, inappropriate treatments, economic costs and everything like that, if that process doesn't go quite according to plan. And so today I'd like to start with the way I've done it, and I don't say that this is the right way, but it's a little model that I've built up over the years. I've added to, I've taken bits away, but I do this with every patient I see when there comes the decide about using antibiotics. I see it like a performance, and I see myself like an actor on a stage, and that I've learnt my lines and I'm delivering the performance. Once we had the opportunity of seeing Hamlet done by Year 12 at Gosford High, and it was a great little performance, and it went very well, and we all applauded at the end. And I'm not quite sure I understood what was going on. Shakespeare can be a bit complex. Strangely enough, a couple of months later, we went to the Royal Shakespearean Company in Stratford upon Avon, and we saw them do Hamlet again, and it was amazing. Our kids were there, and they were only 7 or 8, and they completely understood what was going on. They laughed at every joke that was going, and it was just an extraordinary performance that's lived in our memory. And it sort of highlighted to me that if the actors know their stuff and the actors do the performance properly, it can be quite an extraordinary experience. Whereas if the people just do their lines that they've struggled to remember, you can be left confused and bemused, sort of thing. And so I see myself like that. And if I can do a good performance, then the audience, our patients, will be, well, not only entertained, but understand what's going on. So I'm about to share my screen with you now. Hopefully this will all work out. Start the broadcast, and hopefully you can continue to hear me while I go to my whiteboard, which is obviously my, flash there, I go to there, and there, hopefully there we go, we've got our screen up. I'll go to my A4 page, which is what I use, and I'll just hit rubber and I can rub that out. I'm getting so much better at this, you probably recall when we first started. So I can click here and get the color. I think I'll go for black, and I've worked out that if I talk and write slowly, it comes out much better on the screen. So if somebody comes in with an upper respiratory tract infection, and I'll put that in quotation marks, these folk often have a cough and a cold and sore throat and sore ears. They feel yuck, but also they have mucus, all sorts of mucus. I can just shrink that down a little bit. There we go. And the dilemma for us as doctors is, could this be just a good old virus, or could it be a bacteria? And the reason we want to try and make this distinction is, well, obviously the bacteria antibiotics can be helpful, and viruses, it's just a time thing. And just on time, we've learned a lot since COVID's come along, and we know that when viruses come, they build up and up and up, and then eventually they go away like that. Interestingly, and as we found with COVID, it's in the first 4 days before you're very sick, that's when you actually pass the germ on. It's often at this time here, at the height of the storm, where people think, geez, I'm crook, I'm going to go to the doctors. By the time they get to the doctors or get some treatment made up, a lot of folk are actually already on the road to recovery. And so if the doctor stands on his head or prescribes something, people tend to get better, not because of what the doctor did, but they were going to get better anyway. And what's fascinating with the new studies that are now available, that these viruses, and they found the same with COVID, from absolute beginning to absolute end is 21 days. And so this idea of a 24-hour virus or even a 7-day virus is a bit of an urban myth, probably perpetuated by drug companies trying to sell their products to us. And to be truthful, the only way I've worked out whether it's a virus or a bacteria is if it's going on and on and on, or if you were getting better, it takes a turn for the worse. Then yes, fair enough to perhaps think about antibiotics. However, and we did the same study in our surgery, we were starting to swab everybody to see what happens, and you find that viruses probably make up about 45%, and bacteria only about 5%. So it is about 9-to-1 virus bacteria. But if you do the sums, you quickly realize 50% no infection. So even though these people feel they caught something from the lady across the road, half of them actually don't have a germ when you swab them. And that then raises the possibility that quite a chunk of these people are actually suffering from allergy. And that the reason the lady across the road is coughing and wheezing is she's breathing in the same air as you. And it's not that you're passing germs backwards and forwards, it's that you're allergic to the same dusts or pollen that are in the atmosphere. And we think about allergy if you have a past history of it, if you have a family history of it, if you have any other allergy disorders, such as eczema or hay fever or something like that. But to be truthful, the main way we often diagnose allergy is a response to therapy. And when you respond to therapy, it should actually be a wow factor. And I've come to understand that unless you get a wow factor, most of your treatments probably haven't worked. And so, and this was pointed out to a patient who had asthma and allergies, and we put them on Singulair, Montelukast, and the parent came back and just went, wow, this is fantastic. Why didn't you give me this months ago? Why have we messed around? And that stuck in my mind, this concept of a wow factor for the treatment. And the thing about allergies, though, is that they can affect our nose and then affect our chest. But when it affects our chest, well, we call it asthma. When it affects our nose, we call it rhinitis. many of the symptoms that people get actually stem from their noses, and it depends a little bit on how you're constructed. Half the people, the mucus seems to run out the front, and then they sneeze all the time, and they've got a runny nose, and their kids are wiping their hands across their faces. The other half of the population, the mucus goes down the back, tickles the throat, and makes you cough. Of course, at night when you lay down, and I demonstrate this to patients lying back, the mucus all goes down the back, tickles the throat, and makes you cough. And this can explain why when the doctor listens to the chest and says, oh, everything sounds fine, but the patient says, oh, I was coughing all night, doctor. Also, it explains why prednisone, which does treat the nose and the chest, can be a wow factor in all of this, because it's one of the few medicines that does treat both the upper airway and the lower airway. Now, the other fascinating thing when they've done studies on this is that none of the symptoms, oh, now I might change coloured pen just for fun here. There we go. None of the, whether it's a virus or a bacteria or allergy, none of our symptoms actually are any help, not even the colour of the mucus. So you can have green or brown or even purple mucus. I've never seen that, but anyway, that isn't actually any guide. About the only thing that does guide us is the temperature. That these guys, viruses and bacteria, will give you temperatures, whereas allergies don't tend to give you temperatures. But even that's a little bit tricky because temperatures can be a bit up and down. And so it depends a little bit just when you measure it as to whether you've got a temperature or not. Then finally, to make our job super difficult, it's recognised that viruses, or now another coloured pen, I think, there we go. Viruses are a very powerful trigger to the allergy process. And so these people get almost a double whammy. So they contract the virus, and then it seems to go onto their chest and linger there for weeks and weeks and weeks. And that's a fairly typical story of this virus is triggering the allergy process. And these people make up about 95% of the folk who come to us as general practitioners. So as I say, this is what I explain to patients, and it's probably remarkable. You'll think that I can just do it over and over again. People say, oh, Ian, why don't you just do this as a printout and hand it out to everybody? It'd save you a lot of time. The modern educational theory says that if you, people learn by vision, people learn by hearing, some people even learn by smell and music. And this sort of thing is a way of trying to trigger their learning processes. And if you build the model in front of them, they're more engaged with it. Quite often I find people adding in their own pieces of information, which adds to the diagnostic process for me as well. They might say, oh, I've already had steroids, it never works for me, or something like that. Another doctor in another place has tried this or that. And so building this up, and then the person can take it away with them. And that seems to be an important process as well. My dad used to hand out lots of things because his colleagues used to give a prescription as a way of terminating their consultation and for people walking out with something. He didn't want to do that, so he gave them printed out brochures. I've taken that the next stage further of building the brochure for them, because once again, the educational theory says that that's more engaging. People are more likely to hang on to the information, particularly as it's being given to them there on the spot. There's a high chance with brochures that they won't even read it once they get outside. So as I say, that's what I've been doing. I'd now be very interested to hand over to my colleagues and hear what they do, or whether they can add to it, or think, no, Ian, that's a waste of time.
Well, it's obviously worked for you so far, Ian.
Very good. So I'll just get out of this now, go back to stop the presentation and hand it back to the group.
That's great. Yeah, thanks, Ian. That's very insightful. And I think the allergy is something that a lot of us probably miss and don't address with a lot of our patients. I tend to bring that up if it's a post-viral cough that's been dragging on and on, rather than in that initial consultation. So that's interesting. I distinctly remember as a new GP, when I got to the point of the examination, listening to their chest, and I'm thinking, the patient's back's turned, and I'm thinking, okay, there's no signs of bacterial infection here. How am I going to get out of prescribing antibiotics? I was always felt under pressure. I thought that's what they wanted, that's what they needed. And with a bit of experience, I figured that they don't always want the antibiotic. It's not always on the agenda. So really trying to suss out, okay, have I got one of these patients in my office that is wanting an antibiotic, or do I have that parent that doesn't want to give their child an antibiotic? And that very much doesn't impact my decision as much as the way that I will sell my decision to them. So I guess I just made a few little notes. I don't have a formal presentation and a routine, but I guess it's that kind of shared decision making and that patient-centered approach of what is this patient got in their mind, what's their agenda. And I guess I'm thinking mostly the parents with the young children that come in with the ERTs. There's a lot of education that I do around how this is normal, how preschool age children will get a dozen infections a year and they're clustered into those winter months. So yes, it does seem like they're sick all the time, and they are, and that's normal. And I guess also saying they are sick. I don't like the term just a virus. I think a lot of parents seem to feel that is dismissing their concerns about their child. So I say, I can see this child is very sick, and you poor thing, it must have been terrible being up all night with them. But there's no evidence of a bacterial infection. I think they've got a nasty virus, and sort of giving them that reassurance that we're listening to their concerns. And this is the best way to treat them. We don't want to give them unnecessary antibiotics. These are the possible harms for your child. So the population approach of, we're going to get antibiotic resistance doesn't always impact that parent that's worried about their child. But to say, your child could get a bowel upset, they could get thrush, and if we use a lot of antibiotics in their early childhood, that could mean if they do get a serious infection one day, that we're going to have less options to treat them. So I guess really centering that message to the patient. What do you think, Kelly?
I was just thinking as you were saying that, but I think unfortunately we had COVID, but I think it actually helped a little bit because everyone didn't really understand when we would say viruses don't respond to antibiotics. They said, but I just need it because it's going to help me. I think that the whole rhetoric around COVID not needing antibiotics as well, and we didn't have antivirals, and what are we going to do? I think people really started to understand the difference between the two. So I say similar to we wouldn't give you an antibiotic for COVID, this is kind of a similar thing and it's completely different. So I think that's a really interesting point. Yeah.
One of the things that I read somewhere, and this is one of the dangers, you read it and it just locks in your memory forever and ever, is that I read somewhere that in Norway, they won't give you antibiotics unless you've been to the doctor twice. In Sweden, they won't give you antibiotics unless it's a life-threatening illness, which is interesting. And certainly the Scandinavian countries have a much lower antibiotic prescribing rate than we do. Australia is actually one of the highest. America's the highest of all. That often, hinges around the idea that there's this commercial arrangement going on, and that I want this patient to come back. I want them to be my patient, so I'll give them what they want. And so that pressure is got quite strong in Australia. Not so obviously strong, where there's a sort of national health. I'm sort of mindful of all these factors of the work. We also have Joseph, a medical student, with us. He's had another perspective. What's your thoughts, Joe?
Yeah, thanks. I think as students, often because you kind of just want clear answers as a student, because you have like exams coming up and all this. So usually the thought is when it comes to things like this, or like ERTs and all that, and how to manage it, it's often like, there's no clear answer. And then you ask a GP and you get a different answer based on the GP because they practice differently and all that. I remember on my GP placement, I was following 3 GPs. So during the week, I'd sort of jump between them. And of course, we saw like upper respiratory infections, and the practice was so different. And I remember asking, what's the thought process here? And of course, it differs by patient and all that. But pretty much all the time, it was always like, I didn't really know, but I gave this just in case. And it's sort of like, yeah, I can see that. But it's also in the back of your head, like, the antibiotic stewardship and all that. But even that is kind of like a vague thing, because there's no clear-cut way to kind of go about it appropriately. But I know that when, because often we get senior students teaching us and things, I think when they go over like different ways to kind of stratify the probability of someone having a bacterial infection versus viral. That was really helpful, and I think students really attached to that. So the one that we got told about was like the Centaur score, and then that gives you like a probability of how likely they are to have a bacterial infection. And yeah, all of the students, including me as well, I was like, oh, that's good. That's the answer. Okay, I can use that every time now. Of course, it's probably not like that, but at least for students, that's like enough to be like, yep, okay, I know that now, and I can at least somewhat try and manage that in some way. But yeah, when it comes to these things, it's often very hard as a student to know. And you often sort of think, oh, I feel like as a student, I may not actually, I feel like I don't have the proper experience to really criticize GPs and things. So often you sort of take what they do as, oh, this is the right way to do it, and you sort of take it on board. So I think that's also pretty common. Yeah.
Dimitri, a little story to follow on from that. You might remember Professor John Howie in Edinburgh. He did a study when I was over there where he sent a scenario out to all the GPs in Scotland. And the scenario was a patient comes in, a young 19-year-old girl. She's got a sore throat. It looks a bit red. It doesn't have white spots on it. She has an exam in 3 days' time, and she's very keen to be better by the time the exam comes. Would you prescribe for this patient? And it was about only about 20-30% would prescribe. The other 70% said no. You know, antibiotic stewardship, she's mostly got a virus. She doesn't get the antibiotics. They, about a month later, sent out another scenario, identical, except for the fact that she was the professor of microbiology's daughter. And they found that the prescribing rate was 95%, and that these other background influences played played a big part in why GPs prescribe or don't prescribe. I don't know if you've got any comments on that, Dimitri?
I think that's really important. And we know that Indigenous populations should probably be more likely to prescribe because there's higher rates of bacterial infection and there's such awful outcomes in terms of rheumatic heart disease and so on. But I notice, Ian, that Chris and Gordon both have their hands up.
Who was
So
first? Was it Chris or Gordon? Oh, Gordon looks ready. You've got your face on, Gordon.
I think Chris was first, actually. Okay, but it's all good.
Chris, fire away.
Cool. Thanks, Gordo. I was just going to say, because I think there's two things here. There's the communication of during the consult, and then there's the actual clinical management. I think one of the benefits I've had of these being able to see in lots of different registrars is being able to see all the different ways that doctors manage these consults. And I always learn something from the registrars when I watch them. But for me, the key points that I've taken away from most of these consults is the importance of a good history and examination. If you do a good history and examination, the patient is much more likely to listen to your management at the end and be happy with your management. Whereas if you rush through it, they don't believe you. They don't have trust in you. So when you say, oh, it's just a virus, see you later, they go, oh, I think I need antibiotics. And I think the importance of a good spiel. So, and I've seen lots of variations in spiels over the year, but a good spiel, explaining this is what I've heard this history. I've seen this on exam. These are the reasons why I am or am not prescribing antibiotics. And they do it in a really nice, clear way. The patient goes, yep, fine. I think you can't underestimate that. And also just being really careful not to assume that the patient always wants antibiotics. I've been surprised so many times when I thought, oh, this person definitely wants antibiotics. And you go through the consult and they go, oh yeah, I didn't really want antibiotics. And you go, oh, why did I get all this trouble? So I think just avoiding that assumption, because I think most people don't want it nowadays, depending on where you work.
And Gordon.
Yeah, so that's a really good point, Chris. Okay, and I love how you actually said, okay, patients don't always have a hidden agenda of wanting to have antibiotics. One of the things I found, which we haven't spoken about yet, I think, is the pressures of how long it takes to come in to see us as GPs in the community. So I'm finding myself often writing scripts for patients of antibiotics to actually start in a few days' time or a week later. And I actually put that information in the actual comments box or two. So therefore, okay, if you know better by the weekend, please start this, which is going to be 1.5 weeks time kind of thing. And be able to actually have that buffer in place just to actually help to make the whole kind of communication that a bit clearer, because the other person does forget, and if you can look back on the script itself, they can then actually see it. And knowing as well too that majority of times there'll often be a week or two between myself being able to see them again. That this could be a safety net that I've used.
That's a terrific point, and we've had a little bit of a discussion about expectation scripts. I'll hand over to our other panel members. They've done some thoughts on that.
Oh, well, I found an article the RSCGP had done a study where they did just that. They studied.
Oh no, am I in trouble now?
Oh no, thank you for bringing that up.
We're coming to get you, boy. You start running now.
No, and in fact, this is what's happening in the real world, and we know that, and we all do this. There was a study where they looked at the randomized control trials where doctors had no prescribing, expectant prescribing or delayed scripts, or given antibiotics. The outcomes were reasonably good. So giving delayed scripts does reduce the use of antibiotics overall. Not all those scripts are filled. It gives the patient a sense of satisfaction. There were no worse outcomes from delayed scripts versus giving antibiotics. So that was available on the ICGP site anyway. And there's a bit of discussion about the best way to do that, and I'd be interested to hear what people do. Gordon, you mentioned that writing the comments and what it's for and when to use it, which I think is really important. There was also some discussion about having scripts that expire maybe 2 weeks after writing. I don't know how many of you have had the patient that comes back and they said, "Oh, I've had this UTI," and I used that amoxil that I had in the cupboard, but it was a delayed script from 12 months or 9 months earlier. So making clear that this is for a respiratory tract infection or for a UTI or whatever that use is. And I think the expiration date is something that I hadn't done before and would save a lot of inappropriate antibiotic use. So this is to use for this particular infection if it doesn't improve.
That's a very good point. I read a study about 15 years ago where writing these scripts, they invariably got used for something else. So I sort of moved away from that. But more recent studies, you've got to take these on board. And particularly if you can, put some of these caveats on. I'd be interested to know whether pharmacists are obliged to issue or not issue based on what I write on the script, are they?
I'm not sure. But the guidelines for otitis media, for example, say you can wait for 48 hours. So there should be ways of doing that. Obviously, they would have to go along with your script.
And I just wonder with electronic prescriptions, we would have to, so write it in the comments box. That would still be translated into the electronic prescription, I presume. Yeah.
Or the dosing instructions.
We can cancel those too.
Yes, true.
So maybe we remind ourselves to cancel them in 2 weeks' time.
Well, that's an interesting idea.
The other approaches that were discussed in the study were things like you don't actually give them the script on the day, but we can leave it with reception and the patient can phone tomorrow or the next day if they want to then come and collect it or have it sent to them 24 or 48 hours later. That might reduce some of that inappropriate use. Or obviously, as you say, Gordon, they can't necessarily make a second appointment. That's not really practical or good use of our time. So,
And there's a comment in the chat box from Sam, obviously with the shortage of antibiotics, that's been another good excuse in our toolbox in terms of why we're not prescribing because of the availability. So, so I think that's been sort of a positive impact in terms of explaining to patients the need for antibiotics. And I like using the number needed to treat that we used to learn at the GP Synergy Supervisor Workshop. So if you say you've got to treat 20 people with antibiotics for one person to get better a day quicker, versus 1 in 14 get side effects such as a rash or diarrhea or vomiting or vaginal thrush, that always scares off patients as well.
One of the things that still will struggle, I think, for the next 40 years, if I'm still going as a GP, whether to prescribe or not. We recently did a study on a device called the Fibridics, and it, on a pinprick of your blood, it could tell you the C-reactive protein, whether it was over 20 or not, and whether there was the presence of viral proteins in the pinprick. And this little device, it only took 10 minutes to get a result. I thought would be the answer to my problems in helping decide black and white. Is this a virus or a bacteria or possibly allergy? We found that actually most of the tests were negative. In fact, out of the 30 tests, only 2 were positive. We thought long and hard about this, and we came to realise that the test was only really useful in the first week of the illness. And many of our patients over the years have been taught that your illness is bound to be a virus in the first week or 2, so don't come to us until you've been sick for 10 days. And so this device wasn't very helpful. In fact, it ended up probably delaying treatment, because part of the study was to follow people up with telephone calls after they participated in the study. And we actually found that half the people who didn't get antibiotics as a result of a negative test ended up needing to go on to antibiotics. And it highlighted to me that there are still people out there that need antibiotics. And that, yes, once again, time is probably our most valuable diagnostic tool, and that we do need to find ways of leaving the door open, which is where telehealth has actually come in. I'm not sure about this. I'll put you down for a telehealth in a week's time, and if you're still not right, well, then just over the telephone, we could prescribe you antibiotics. So that's another sort of approach that I've sort of worked out thanks to telehealth coming in. I don't know, is others using telehealth that way?
I think just to what Chris said about examination, when I started work last year as a GPT-1, I was like, oh my gosh, how am I going to explain to them that they don't need the antibiotics and that sort of stuff? But I found that doing my exam out loud, so, oh, I can't feel any lymph nodes, or I'm missing the chest, and afterwards I would summarize, oh, it sounds okay to me, and just writing this down in their notes, I would write out, I would type out loud as well. And I think that really helps. I think that you can't explain to someone, you don't need antibiotics for your throat if you haven't actually looked at the throat, obviously. So I think doing that was really helpful. I just wanted to raise a point that I'm still struggling with, in fact, is if you don't give the antibiotics, and perhaps I didn't even want them to begin with, what is it that you do give? So you always talk about taking Panadol. I'm told that the antitussives aren't very good, and we certainly shouldn't give out codeine. So everyone says to me, well, what can I take for this cough? What can I do? And it's like, oh, cough rinses, some warm water and a little bit of honey or something, some lemons. So like, there's not any really good options as far as I know. And I'm interested to know if anyone else offers any good suggestions.
Yeah, I think depends on the patient again. Some patients really want that. Some patients are just reassured to know, okay, it's a virus and it'll get better. There are other patients that really want something, whether that's usually a medication, but can be replaced by handout and information as well. Look, I'm a big fan of hot lemon and honey drinks, and I do say that they've done trials on these things, and they do help symptomatically. And your immune system is going to be the thing that gets it better. Your immune system is going to do that job that the antibiotics would do for a bacterial infection. But I know you feel miserable in the meantime, and these are the things that help. Depending on the patient, I think that decongestant day-night kind of things are helpful if people are very stuffy and they don't have contraindications. But I mean, the children is the tough one, isn't it? And I talk to parents about saline sprays or nasal bulbs, and certainly, hot lemon honey drinks. Any other tips?
Yeah. Oh, well, interesting. The parents with the children are often wanting to do something to the child, and we often hear the story. Oh, he won't take any Panadol. I have to force it in. And the parents got the idea that the Panadol will somehow make them dramatically better. And I've sort of highlighted, well, if the child is refusing, then the child is not so bad. Because that would be my experience as well. If the child takes the medicine, then the child is probably pretty sick. But if the child is refusing, that's actually a rather positive sign. The child's not that sick, and they can just be left to heal up under their own devices. So, sick children like ourselves will take medicine if we're feeling pretty crook, because we're looking for some relief. But if taking medicine is more of a problem than the relief it might provide, the child will refuse it. So I found that a reassuring tip for folk.
What about you, Joseph? Do you have any thoughts and comments about cough mixtures or nasal sprays? What are your thoughts there, Joseph?
Yeah, my understanding, which could be wrong, was that it's basically Panadol, and then everything else is kind of a bit more vague. And And I think I've seen GPs where they recommend different things that aren't as like, that maybe are more just their own, what they find helps. And I think sometimes one GP did really well where I thought did really well where they sort of framed it as, hey, these aren't like, they aren't like evidence-based necessarily, but these are things that I found helpful. And maybe that's also good. But I guess there's also that risk of, oh, this is the way to treat it. Oh, I need to get this. And then maybe they even can't afford it or something like that. So I think it is a bit of a slippery slope with that sort of stuff, depending on how you say it. But I've seen it go really well, and some patients sort of appreciate that more. Like, oh, okay, yeah, I can try that, and if it doesn't work, then that's all right. I know it's not like the actual treatment, but yeah, I guess that's my understanding, sort of like Panadol, and then everything else can be added depending on the patient, and as long as it doesn't do too much harm. But I'm happy to hear otherwise if anyone thinks.
Timothyy's got her hand up there.
Experience.
Yeah. We're now calling on 60 years of general practice experience, Timothy. Oh,
Unmute, Timothy.
I wasn't 10 when I started general practice, but I was a young mum, and the furniture in the lounge room got decorated with Panadol because my child was very resistant to Panadol. So
Obviously a very well child.
I wish I'd had a wise GP to tell me not to worry about the Panadol. If they've got enough energy to spit it all over the place, they're probably fine and going to be fine. But I wanted to ask a different question, really, and I wanted to ask Ian about doing research in general practice, wearing my sort of academic hat. I just wondered if you thought that was an interesting process, in positives, negatives about that process. I know you got waylaid by the pandemic, which is not something we normally expect with research in general practice, but any comments on that? Because to me, it seems like this is the sort of research that really needs to happen in general practice. This testing of a tool that might be very useful in the ED, but not useful in general practice. And in fact, I think Ian's written to the British Medical Journal or something about exactly that when they've been spruiking Fibridics. So any comments, Ian?
Oh, yes. Well, I'd done an MD 30 years ago, so I had a lot of academic exposure and writing ethics committee forms and things like that. But then, yes, I became a GP and played rock and roll drums and things instead. And it's only just recently I did this research project. And it was a bit of a revelation how things have moved on. I thought I'd just get hold of this gadget and use it. Then it was pointed out, well, nowadays, if you want to write about it and have it published and more broadly read, it's got to have ethics committee approval. Otherwise, people won't publish your work. So go and get ethics committee approval. Now, the ethics committee approval was a job in itself. It took about 8 months to get through the ethics committee process. Because I was a bit of a novice at it, I did have one of the ethics committee people who was a very great ally, and she sort of guided me through. And I would certainly be a lot better at it the second time round. But unfortunately, the first time is quite a steep learning curve. And then, yes, you have to accept that things don't go according to plan, but that's actually, you sort of turn that into a positive rather than a negative, that you learnt things about this topic that you hadn't intended learning. And most research is just that you start off with a question, you might get a little bit of insight into the answer of that, but invariably it throws up more questions for you. And yeah, you become wiser and more experienced and gain a better understanding about the whole process because you're involved in some research. So you've got a sort of bit of an inquisitive mind, and you'd like to think that you can make a little bit of a contribution to the world's knowledge. Well, then yes, it is actually doable with a bit of practice in general practice.
And Ian, tell us about the British Medical Journal letter, because that was a rebuttal of some sort, wasn't it? Could you explain it?
So there's a bit of conniving going on. So this Fibridics device has been used in accident emergency settings, but not ever been used in a general practice setting. And we were the first to try and use it in a general practice setting. But our study was based on seeing people as they came in, but then COVID came and people stopped coming to the surgery, and people were having telehealth and being prescribed things over the telephone that we couldn't sort of follow up. So our original research protocol, yes, got sabotaged. And so we found ourselves really having to stop after only 30 patients. We were hoping to get about 150. So we didn't really have the numbers for a full-on study. But we heard from the company that the Fibridics device was being published in an accident emergency setting in the British Medical Journal. So we were ready for it when it hit the press with our response letter and a summary of our study and so forth. And they accepted it within 3 days, actually. And so, yes, our little research project is now part of BMJ, British Medical Journal history. And yeah, to get something published in the British Medical Journal is like having a #1 hit. And so, curiously, even though the study didn't work out as we planned, and it's not been picked up as a major thing, it is now there for the worldwide literature. And if people look up Fibridics, they will see the Charlton Holland's Fenton study as part of the worldwide literature now. So that's been nice that we've got something out of it.
And Ian, their accident and emergency experience was different, wasn't it?
That's right, yes. Accident emergency, they see a different population of people, a lot more children who have turned up just 2 days after they've developed the illness, because nowadays they get turned away from their childcare, and this causes a great consternation for parents. So that's played into the way people present, and they invariably go to the casualty because mum comes home from work and the child's sick and can't go to childcare the next day, and they need a fix overnight. And well, the casualty is often the place that they can hope to get those things sorted out. So these are all changing the way people present and the types of people that present.
The device worked better in that scenario.
That's right. Yes. They had an 80% negative predictive value, which means that it was, and they were able to. They compared their device to laboratory testing. We compared our device to a clinical setting, follow-up phone calls, how you're getting on, are you getting better? They did white cell counts and CRPs and other markers of infection they used.
PCR at all? Or?
Yes. And so they validated their results against different criteria to ours. But once again, it sort of highlighted that different settings and different populations and different ways of measuring give you different results. So they had an 80% negative predictive value, means that if it was a negative result, they were 80% accurate. Our negative predictive value was 20%. So we were much lower, but a lot of folk we thought were negative actually turned up having antibiotics 2 or 3 weeks down the track.
That's interesting. So I think the relevant clinical outcome to measure would be, does that change your management? So it sounds like the emergency study didn't really answer that question. It was just saying, is the device working? Is it giving us the right information? But are you getting the same information from your examination? If you can see purulent tonsils and a high fever, you're going to give the antibiotics anyway. Does that device change that decision making? That's the interesting thing for me.
Yes.
And did they prescribe antibiotics in the emergency, Ian?
They did. They found that it reduced the antibiotic prescribing. It certainly didn't stop. So the doctors, because it was experimental, I think even though there was a negative result, 30% of doctors still gave an antibiotic in some of those accident emergency settings.
Say in ED, as soon as you walk in, you're already plugged in with antibiotics. You're like, wait a minute, I've got a fracture. It happens very quickly, so I can imagine that. It wouldn't change much. But I think in the GP setting, the CRP would be very interesting to know about. It was a quick little test, and also good as a patient to say, oh, actually. But again, we talked about the fact that it may or may not actually be useful. So
Yeah.
I just wanted to also ask people if the recent strep A outbreak has changed people's behaviours, because I'm certainly swabbing more throats than I did before. And I don't know if I'm prescribing more antibiotics, but certainly I've had a couple that have come back positive and then I've prescribed, so where I perhaps wouldn't have prescribed in the first place.
Was it pure?
No, well, there's a couple, well, I'm thinking of 2 patients in particular. One, the family members had all been sick and I thought, oh, viral, and I'd swabbed, but then the patient came back and said, well, actually, my sister's now been given antibiotics and told she has strep A. And sure enough, her throat came back strep A. She was probably in the early stages when I saw her. I followed up for another GP here, so I didn't examine that patient, but a swab that came back on that GP's day off that was strep A, and obviously that GP hadn't prescribed on the examination findings either. So whether it was just too early, I don't know. And I perhaps wouldn't have swabbed those people a year ago. Has that changed people's behaviours?
About 5 years ago, when swabs started to become available, I swabbed everybody. I did my own little study, courtesy of Laverty, paying for everything. And I was surprised. It was a sewer down there. There were viruses, there were multiple bacteria, even multiple viruses, you know, and it left me confused as to whether do I treat the virus or do I treat the bacteria? Because in 30% of cases, yes, we've got both turning up. Yes, I became disillusioned with the idea of swabbing. That was a different setting. You know, if you've got a virulent streptococcus going around and it turns up, you know, I'd probably be thinking that's worthwhile treating too.
Are there any harms of swabbing? Is there a reason we shouldn't swab potentially then?
Which is the cost.
The cost.
And the delay. I think if you get the feeling on examination that this is bacterial and this person's quite sick, you don't want to wait 48 hours. You're just going to prescribe anyway. So I guess you choose the patient that's going to change your decision. So I tend to do it on those ones that I'm not quite sure about. Particularly more recently I've done more. And through the pandemic, I guess, as well, not just COVID swabs, but the other respiratory PCR virus swab was very popular, obviously, because parents wanted to know that it's not COVID, but it is such and such. And just having that RSV diagnosis, or, you know, is kind of reassuring.
It's an influenza outbreak as well. It's really, really, really sick patients. And then that just, influenza A.
I'm interested if anyone uses the centre that Joseph mentioned, the mnemonic.
We haven't heard of it.
You're not familiar? I actually know that, and I use it intermittently, but I'd forgotten about it, Joseph. And it could be worth using again now with strep around. Can you remember what it is, mate? Or am I putting you too much on the spot?
I can get it up.
Wow, these
Good.
While
Joseph's doing that, I'll just comment that I saw someone with a real red strawberry tongue and a nasty red throat the other day, and I just gave them antibiotics straight away because I thought this looks really like strep. I hadn't seen anyone with such a red tongue with little you know, lumps on it for a long time. You got it up there, Joseph?
Yeah, so it looks at age, exudate or swelling on tonsils, tenderness, swollen anterior cervical lymph nodes, temperature of 38, and cough. And then I'll just stick in random ones and just see what it comes up with. Yeah, so it gives you like a percentage range based on those. So if you score like 1 point, it's 5 to 10% likelihood of strep, and you don't need any further testing nor antibiotics, it says. So I think it just helps guide that, but it doesn't give you like a hard answer, of course.
That could be useful though, couldn't it? So how do you spell it when you look at it?
CENTOR.
Yay. Okay.
Centaur score for strep pharyngitis.
Now we've got 3 minutes left, and just to really maybe for next year or something like that, how do you treat antibiotics when you've got antibiotics have got a sore red leg? Is it cellulitis or is it just congestion? Is it venous congestion? If somebody's got a sore and they've got a bit of an ulcer and it looks red, how do you know whether that should just be treated with leg elevation or treated with antibiotics? Whiz around the room.
You've just stopped yourself in for the next topic. For the next presentation.
I think the answer is going to be similar to what we've been talking about. It's very situational, depending on the patient, their comorbidities, the timing, how long it's been going on, there are other risk factors, all of that. And again, that continuity, that time that we have as GPs to observe over days, come in and see the nurse for a wound dressing or a review. It doesn't take too much of our time. And we can, sometimes maybe we can afford to wait for a swab for this one if there's a wound. So no right answer, no right or wrong answer there.
I got very frustrated with my colleagues that would write in their ED notes bilateral cellulitis, and I'll be like, no, did anyone check the heart? Is there fluid in the legs? Like, it's not just, let's just give antibiotics to everything. There's many other things it could be. So.
Oh, excellent answers. I'm amongst a group of geniuses. And sebaceous cysts. I went to a supervisor talk, and after 25 years, I heard a supervisor said, nah, never give antibiotics. What? For that big red pustular pimple, you never give it? Nah, it's inflammation. Just drain it and it'll get better. And I was flabbergasted to hear this from a fellow GP that antibiotics weren't needed for red sebaceous cysts. Quick answer there?
No quick answer. Again, it depends on the scenario and the degree of tenderness. I do give antibiotics if it's looking paranoid. Add into it as well, potentially, depending on the patient and their comorbidities and other medications they're on.
And if they've got any systemic symptoms, if they feel unwell with it, fluid, you might be more likely to treat in that case.
Timothy, Joseph?
Can I make a general statement that's not, because we're nearly at the end, which is that we are doing an evaluation of the vertical integration program, and some of you may receive an invitation to be interviewed by Joseph or his colleague Natasha, and I'd ask you to look at that invitation kindly if you receive one.
Ignore that email. Yeah. Awesome. And while we do the wrap up, I'll also do a little plug too for our, instead of a vertical integration in 2 weeks' time, we've got actually GP Club on Thursday, the 2nd of March. It's an evening session. It's on musculoskeletal medicine. We've got a great lineup with Jonathan King, who's a local sports medicine physician, and some local physios. So it's a free feed, a great educational talk by Jonathan King, and then some clinical skills stations, because musculoskeletal is something that we often feel like we're winging a bit. I don't know about you guys, but I often do. And then our next vertical integration morning will be with Gordon Lau, and that will be in a month's time. And that's on mental health e-resources. So invite a friend. It'd be great to have more of you on board. But I'm sure you'll agree that it was a great panel discussion with our experts here and Joseph online. Thanks for crossing in. And it was a great discussion. And I think if people come back, go back and replay this, they'll get lots of nice little spiels that they can use to their patients as well. So some great tips. So thank you very much. And I'll hand you over to Jenny.
Just have fun. I'm going to share my whiteboard with people, and Jenny will send it out to you all, and you can look at my scribbles and scribble back on it if you like.
Thank you very much, everyone. I certainly got a lot out of this morning. I found it very interesting as a layperson. The worst thing is these viruses can just go on for weeks and weeks, and it's very hard when you have to go to work, as you all know. So I did put the Slido link in the chat. So if you could quickly fill it out, it'll only take you 30 seconds. And I will see you all again on the 15th of March. And Gordon, I will fix up your problem with not receiving my emails. I am very sorry about that. Thank you very much, everybody. I might just get Georgia to stay on, just so we can have a quick chat.
Thank you.
Awesome. Thank you.
Thanks, everyone.
Oh, good. I had lots of work now.
Off to work, yes.
Have fun, Gordon.
We haven't enough time to do everything you want. We didn't even get to the colour, it's not discussion.